Rajagopal sir. I'm sure he doesn't need any introduction to any group of doctors anywhere in India. He's the director of the WHO Collaborating Center at Trivandrum, and he's the founder chairman of Pallium India. His initiatives to remove regulatory barriers in availability of oral morphine in pain relief have contributed to the simplification of narcotic regulations in 17 out of India's 29 states, and most recently to the amendment of the NDPS Act of India. His initiative has also contributed to the development of a government policy on palliative care in the state of Kerala in 2008, and the government of India's national palliative care strategy in 2012. The international organization Human Rights Watch has honored him with the Alison DeForges Award at Los Angeles in 2014. He was named as one of the 30 most influential leaders in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine in 2017. And in 2018, Dr. Rajagopal was honored with the Padma Shri, the third highest civilian award given annually by the Republic of India. Is sir still with us?
Yes, I am here. Sorry.
Sir.
Hello.
Thank you, sir. For,
Ashok.
It's an honor to be in this session once more with you. I think we are running a little late, so we'll go directly to the session. Today's session will be about RMI practices. Over to you, sir.
Thank you. Thank you, Dr. Ashok. Sri, you have the PowerPoint with you? My last period availability PowerPoint?
Yes, sir, I do have.
Can you please put it on? But in the meantime, so glad that you're all here. This kind of course for oncology is going to make the most difference to patients. And when we say patients, very often we think about them. But at my age, I'm talking about us. Because I know that I have at least 10% chance of getting cancer. But then I realized that when I was getting angry and cursing everybody, I was being reactive. I was reacting to the situation. That approach does not help. Later, I realized that I had to be proactive. Instead of getting angry, I needed to ask myself, what can I do about it? And when I started asking that question, I realized, Sri, can you switch off the permit? Can you close the PPT for a moment? So can you stop the screen share for a moment? I'd rather see people's face and talk for a few minutes more. So I realized that to be proactive, I had to ask myself, so what can I do about it? Then I realized that this is the nature of any change. Dr. Karthika and Dr. Vinayak, do you have access to oral morphine in your institution?
Yes, sir. I have access to oral morphine, sir.
Dr. Karthika?
Sir, I just completed, sir. I'm looking for job now.
So you are not sure where you go and whether it will be available. Dr. Megha, can I ask you, do you have access to oral morphine wherever you are working? You are muted, Dr. Megha.
Sorry, sir. We have a separate pain and palliative department for the same. So we generally refer them there.
Okay. So, Dr. Megha, in your perception, what do you think will be best? Referring to palliative care unit or being able to prescribe it yourself to your patients?
Me being able to prescribe would be the best solution.
Sorry. Where do you work, Dr. Megha?
I am currently doing my senior residency in radiation oncology in Government Medical College, Kozhikode.
Okay, okay. Dr. Jacob John, how about you? Access to oral morphine?
Yes, sir. We have.
Sorry,
We have access.
you can prescribe, doctor.
Yes, yes.
So when I found that I couldn't, like Dr. Megha, has to refer the patient to palliative care unit. Uh, the World Health Assembly resolution asks all member countries to integrate palliative care into all healthcare. This is fine for early days, Dr. Megha. It is reassuring that you can refer a patient and they can get pain relief. But for ordinary pain situations, it would be much more efficient if you yourself treat the pain and have to refer the patient to palliative care only if pain is severe. This is what we envisage tomorrow, for which fighting doesn't really help. You have to analyze the problem. Where exactly is the catch? Is it in the law? Is it in the rules? Is it the hospital failing to place the order? Is it the pharmacist saying, no, I don't want to take this on. This is terrible. We have to identify the step and then act at that particular step. Otherwise, our patients do not get pain relief. If your patient does not get pain relief, you don't get enough satisfaction out of your work. It's as simple as that. Unfortunately, we are in a profession where your happiness depends on how happy your patients are. Though we often do not think about it much. That's the truth. If from morning to evening they are all cursing you, you go home and start fighting with your spouse and children in the evening. So this issue then told me that this has numerous components. The problem were at the legislation, at the policy. As you can see, I was a dog. I became a doctor about a century back. And when I was a house surgeon, I could just prescribe injection morphine. Oral morphine was not available. But a hospital often doesn't have morphine. I could write a prescription, just a double prescription. And the patient's family member goes to the pharmacy outside the medical college and buys it. It was as simple as that. But later the problem got complicated. And then each one of us now may have to go through a series of problems. Like Dr. Megha, will have to send the patient to palliative care unit to be able to treat pain. And everybody may have his or her own challenges in this matter. So what am I saying? I'm saying that unless we try hard, we may not get to the situation where you are able to treat your patient's pain. It's not fair to send the patient away for every patient. Difficult pain, by all means. Okay, now, Sri, thank you very much. Can I have the slide on again? Next one, Sri. So I'll start by reminding everybody that health is not an absence of disease or infirmity, that it is physical, social, and mental well-being. It is physical, social, and mental well-being. So we are being healthcare providers, we have to bring in well-being. His social problems or his emotional problems cannot be addressed unless we treat what is foremost, what's in the forefront, and that is the issue of pain. Pain is overwhelming, and when it fills the mind space, you have no space for anything else. Sri, next one, please. Sri, is it possible to give the poll to everybody? I asked, sorry?
I have to just check the possibility from Vaishnav's end. Vaishnav, can you just launch one poll? possible.
If it is take time, it's okay.
By
Vaishnavi, can it be done right away?
by 2 minutes, sir. Please.
Okay, then don't bother. Sri, next one. I have already asked the question to a few people. There will be some people who do not have access to morphine. Again, I like to skip the poll because I'm sorry. My apologies. Sri, I should have sent this to Sri earlier. I'll remind everybody again that as defined by the Indian Council of Medical Research, a healthcare provider's duty is to mitigate suffering.
Rajagopal sir, Vaishnav, do you have?
Ma'am, I hope we lost Rajagopal, sir.
We lost his connection. Apologies, everyone.
Sri, please go on to the next slide. So I was asking you, Sri, to share this slide, this deck of slides with everybody, so that those references for anybody's perusal will be available. So, doctors, we have this dual responsibility. It is something that the world accepts now, that we have a dual responsibility concurrently, because many countries, including India, are worried about abuse of opioids. Yes, it is our duty to also prevent abuse of opioids. I put that in first because it is not only your duty and mine to make opioids available. We also have the duty to make sure that it is not diverted. We have the duty to make sure that it's kept properly. It's okay. The pharmacist deals with it. Now, I don't dispense the morphine in my institution. The pharmacist does it. But as the doctor in charge of the recognized medical institution, I periodically check it, or I delegate somebody to check the stock periodically. If there is a shortfall of 10 tablets, we go into it and find out why it is so. We try to avoid any discrepancy. So let me highlight that. We are not only talking about item 2, we are also talking about item 1, recognizing the principle of balance. Next, please. We have a million people with cancer pain in the country, maybe more than that. Okay, at least a million with moderate to severe pain. The total number must be something like 1.5 million. Less than 4% of them have access to pain relief. We want to not only to ensure access, but also to make sure that it's uninterrupted access. We have to assess the barriers and take remedial measures. If all of a sudden the pharmacy says, sorry, we are running out of morphine, there will be no morphine tomorrow, we need to find out why this happened and to take remedial measures to make sure that documentation is proper, and we want to continue to advocate for access to pain relief. Sri, next one, please. Now, I told you that as a house surgeon in 1971, I could prescribe oral morphine. Now, you write a prescription for injection morphine. You can't get it from the pharmacy. What changed in between was this law. In 1985, India brought out this draconian law. Recently, there was a talk by the famous journalist Shekhar Gupta. He says, in all democratic countries put together, our NDPS Act is the most draconian act. See how thick the book is. This was brought out in 1985 with the express intention of preventing abuse. it was not meant actually to encourage use for pain relief. It did permit it, but under with great complications. So finally, after 19 years of efforts, we could get the Parliament of India to change the law. So since 2014, we have the amended non-narcotic drugs and psychotropic substances Act of India. When you were studying oncology, you never thought we may have to learn about law and changing it, etc. I won't bore you with a lot of stuff, but only with some basic essential facts. So, Sri, next one, please. Till 2014, we needed several licenses. We needed a possession license. Some of you your hospitals may still be going through that formality. You may be requiring several possession license just permits you to possess at one time so much. And then you also have to get an import permit from the excise to get to bring it from another state. And that state will have to get an extra export permit. I don't know if there is anybody here from Tamil Nadu, including Tamil Nadu. Several states also need a transport permit to take it from one place to another, one district to another district. And all these involve multiple agencies, including excise departments. The licenses had short validity periods. Now, I know that though the law changed, some states are still following the old practice. You see how tricky it is. We have to make sure that the states follow the new simplified amended rules. Now all states have the same rule for essential narcotic drugs. So-called recognized medical institutions or RMIs approved by the state drugs controller do not need these licenses. You understand? If the land is practiced in the state, none of these licenses are necessary. You don't need a single license. You only need one certificate from the drug controller saying that your institution is a recognized medical institution. Recognized medical institution for stocking and dispensing essential narcotic drugs. Sri, can you stop the screen share for a minute? I have more to talk about, but are you with me so far? Is this clear, what I have just now said? Do we have anyone here in this team who doesn't have access to who doesn't work in a recognized medical institution? Would somebody like to speak out? Okay, Sri, there seems to be no question. Please put the slides back on. So, recognized medical institutions approved by the drugs controller do not need any of these licenses. You keep the certificate of RMI, order the medicines, place the order with the manufacturer of morphine or fentanyl or methadone, and you get the medicine. Sri, next one. Sri, I have switched my video on again. If my voice breaks, please tell me.
Sure, sir, we'll do that.
No, sorry to bother you with these finer details. Please understand that rules are different from laws in the legal parlance. An act is a law. It is passed by in this context by the parliament, or in some other matters by the legislative assembly. Whereas rules are executive orders created, in this case, in our case, it's a Department of Revenue which is handling it. So the law was passed in 2014, and next year to explain how the law is to be implemented, the government framed the rules. According to the rules, the relevance is if the rules need to be changed, we don't have to go to the parliament. Morphine, fentanyl, and methadone are now essential narcotic drugs. Any institution that is an RMI can straight away order and procure morphine, any formulation, oral injection, anything of these medicines. Is that okay? Please ask a question in the chat, or ask me after unmuting if you have a question. So next one, please. If your institution has to be an RMI, all that is necessary is that one doctor in the RMI has to be named as in charge of RMI. And this doctor should be somebody with training in pain management. Any doctor with training in pain management can be doctor in charge of RMI. This is a mandatory condition. A doctor with training has to be responsible. This was brought in so that people who are handling the medicines will understand what we are talking about, because not everybody understands opioids. The rules do not say what kind of training is appropriate. In Kerala, the drugs controller has approved of online training. So anybody working in Kerala after the course, you can present the certificate of training from this course. That makes you eligible to be an RMI. In other states, the drug controller may not have issued this rule. What we do is we give the Kerala order and tell them this is what is created in Kerala. And generally drug controllers permit it. Online training also. This doesn't mean anything else except that BDS is also okay, but only for being in charge of an RMI. That's all that it means. See next one, please. And yet another point is all government hospitals are supposed to be deemed RMIs. If you are in a government hospital, you don't even need to apply for the RMI certificate. You are an RMI, but you also must keep all the documentation properly, and annual consumption data will have to be provided, whether you are government or not. Next, please, Sri. Now, as the doctor in charge of the RMI, as I said, I don't keep the stock, but I check it periodically and assign the register. Usually I try to do it once in a month, or at least once in 2 months. And I send somebody across to do a bill count to make sure that the balance is kept properly. If every receipt, okay, on this date, 11/4/19, we got 24,000 tablets. I mean, for each formulation, there's a separate register kept. So much was received. And on 19th, on the same day, not on the same day, on the 19th of April, Mr. Shashidharan Nair was given 35 tablets. So how much of the tablet is left there is entered in this list. So when 24,000 tablets were added, they were added to the balance in stock. After every dispensation, the pharmacist or the nurse, whoever handles it, has to keep the stock. This is how we keep the stock register. As I told you, Sri will be giving you a copy of this PPT. So next one, please. Now, if your institution is not a recognized medical institution, how do you proceed? You have to apply to the drugs controller of the state. And in the presentation that Sri will be sending you, this link will be there. If you click on the link, you will get all the forms. There will be a form to fill for approval as an RMI. There will be a form to fill for placing the order with the company. Those things are there. I also recommend that you go to the best practices document. This was prepared by Dr. Nandini Vallat, who is now in St. John's, and it's an excellent document laying out answers to the possible questions that you may have. Once approval as RMI is obtained, you have to place the order with the supplier. The form will be given here. And as I showed you already, the documentation will have to be kept. Sri, was that the last slide? Yes. Please stop the screen share. I have some more things to talk to you about. But before that, I insist on somebody commenting or asking questions. This has been a monologue. I am getting bored of hearing my own voice.
We would request participants to kindly put in their thoughts, their concerns, or whatever their experiences as well. And kindly be assured that there is nothing wrong or nothing right in here. We are just asking for your opinion. So please just speak up whatever we feel.
Anybody who doesn't have access to oral morphine at the moment in your institution, not necessarily in your department, but in your institution, would you like to please tell me what the situation is? Why am I asking this? I'm trying to find out in the actual practice what obstacles you will come across, and then we can talk about the solutions. Sri, is there a case presentation at the end?
No, sir.
Okay. Let me show you an image. Is my screen visible, Sri?
Yes, sir. Perfect.
So if we are to treat pain properly, we'll have several issues here. And I have put in a few issues here. The first is Is it your duty to make the drug available? Doctor's perception of duty. And first, if we accept that, we'll try our best, because to treat cancer, when you treat cancer, you also have to relieve pain. Once we have accepted that, we have to overcome the legal issues, which may be in the hospital itself or in the state machinery. Earlier, we mentioned that if your duty is not only to treat cancer, if you accept your duty is also accepting the responsibility to treat suffering, you will have to make the medicine available. But there, you may have a confusion. Will there be a problem of addiction? What happens? You prescribe morphine. You give them 100 tablets of moral morphine to take home. The man takes it home. Will his children steal it and become addicts? Will the grandchildren take a few tablets and get into trouble? Would you be really worried about that? Do you think with oral morphine, addiction is a remote possibility or a common possibility or not at all a possibility? What do you think?
Common possibilities.
Did Dr. Karthikeya say something?
So I said common possibility.
Dr. Karthikeya, there are a few things that we have to remember. I specifically asked about oral morphine. Injection morphine may be different. With oral morphine, the chance of addiction is very small. It is not zero. Let us not say that it is not possible, but it is very small. The reason is when you give somebody an injection, the blood level rises like that steeply. Blood level rises, and that tends to give the kick, the person getting euphoric. And after a few injections, if given more than the quantity needed to treat pain, they get more tendency to get addicted. There are a few things that we know now. Addiction seems to be a disease with genetic predisposition. There are so many people here, at least a few people would have tried smoking as young men. I did, I must admit. I started smoking, and I found that later, some of my classmates, we all started because I wanted to feel big. I wanted to feel a man and impress everybody that here is a man smoking away. And then I found that some of the others had no problem at all stopping it. One of my classmates planned to go to Shabarimala, and all of a sudden he stopped it. He had no problem. Whereas when I tried to stop it, I had a much greater difficulty. It was very difficult for me. I suspect that I am genetically predisposed to addiction. It appears that up to 20% of human beings may be genetically predisposed to addiction. More likely, easier getting addicted. And especially to those people, if that injection of morphine is given to people with genetic predisposition, especially if injectable opioids are used, especially if opioids are used more than what is needed for pain relief, then addiction is a stronger possibility. In people who are not genetically predisposed, addiction is much less a possibility. This is an important distinction that you must understand. So, Karthika, with the oral morphine, the chance of addiction is very small, very small. It is still possible. I actually had a patient who was misdiagnosed as cancer of the pancreas. A biopsy report came saying that, saying that it is malignancy. The man was put on morphine. And after 2 years, we found that he was still going around happily with his morphine. For the first year and a half, his requirement was steady. And then it started going up. He started asking for more and more. That's when we started reinvestigating it. And at that time, we found that he was not actually having a malignancy. He was having a chronic pancreatitis. And it was a misdiagnosis. This man found it almost impossible to be weaned off the medicine. So rarely with oral morphine also addiction is a possibility. It is not common. With injectable, it's more common.
Okay.
Even with injectable, if it is given only in sufficient quantities to treat the pain, it is much less likely. Any question about that, anybody? And arising from that, Sri, are you still seeing my screen?
No, sir.
Okay. I'm going to show you another image. And here we'll be going a little more into this drug dependence business. Can you see my screen now? Sri, my screen is visible?
Yes.
Yes, sir.
Yes, sir.
Yes.
So now we want to make a distinction between physical dependence and addiction. When I was a house surgeon, I still remember a patient in very severe pain following an accident. He was not given much pain relief. But one day, my senior doctor gave him morphine. And the man he was in heaven for several hours. He asked for the injection again. And everybody was saying, hey, addict, addict. The next day, when the senior doctor came, the person called him again, doctor, please give me that injection again. And the doctor also thought it was addiction. But this is one thing that we have to understand. Craving for pain relief is not dependence. Once we understand that, even then we have to understand that dependence is of two types. It can be physical or it can be psychological. The term psychological dependence is not official. We call it addiction. If you give me opioids for a length of time, as happened to me for a patient with fibrosarcoma over the scapula, he had a surgery done. He was advised radiotherapy, but the man would not, after the surgery, this was many years back, he would not undergo the radiotherapy because he had seen an uncle admitted for radiotherapy and the man had died. He was mortally scared. He did not agree for the radiotherapy. So then he started paying. He still wouldn't allow it. So the oncologist sent him to us and we started him on morphine. The man had excellent pain relief with morphine. He went on like that for a year and a half. But eventually, this started ulcerating. We could control the pain, but from the ulcer, some nasty fluid started seeping. It was a nuisance. Finally, he took courage and said, okay, I'll die if I have to, and agreed for radiotherapy. The radiation oncologist gave the radiation, and about 1 week later, he was drowsy. His pain was reduced, seriously reduced. We started reducing his morphine. In such a case, when somebody has been on morphine for a long period of time, they are likely to be independent. So we stopped the drug, and then what happened was, we started reducing the dose, but the man himself stopped the medicine because he was thinking, I don't need this. I don't have pain. Why should I take this? He stopped it. And the next thing that we know is he ended up in the mental hospital. He was brought to the casualty with severe behavioral disorders, and the psychiatrist was called in, and he was admitted to the mental hospital. Luckily, we came to hear about it. So what happened in his case were the manifestations of drug dependence. What happens with the abrupt discontinuation of opioids after a long period of time? It doesn't happen if the duration is less than 3 weeks. They don't have the energy. They are sleepy. They get disoriented and delirious. Remember, these are also the signs of overdose. Remarkably similar. Overdose of opioids beyond what is necessary for pain relief exactly causes these: sleepiness, disorientation, delirium, myoclonus. The same thing happens here, but in addition, one other thing happens. They get diarrhea and abdominal cramps. You know that opioids reduce the gastrointestinal motility. All of a sudden you withdraw it, and the result is overactivity of the gastrointestinal tract, so that they get diarrhea. So these are the signs of physical dependence. What the man had was not addiction. He was physically dependent. All that was necessary was start him back on morphine again and gradually withdraw the opioids. I would recommend that you withdraw by about 1/3 every 2 weeks. If the person has been on a very long time, say like 2 years, as I was mentioning, and then you withdraw it every 2 weeks by about 1/3 of the previous dose and gradually withdraw it. This is physical dependence. These are not manifestations of addiction. This is a very important point that all of us must remember. Withdrawal symptoms do not mean addiction. Withdrawal symptoms do not mean addiction. Withdrawal symptoms are usually caused by withdrawal in a patient who is physically dependent. Now, in contrast, in psychological dependence, what the person has is craving for the substance beyond the needs of pain relief. Now, Dr. Karthika, where is telling me something?
No, sir.
Okay.
Such.
If there is craving for the substance beyond the need for pain relief, that's a sign. If the person keeps on increasing the dose without your permission, particularly unsanctioned dose escalations, that can be a sign of addiction. very often there are behavioral changes which can be irrational behavior. To procure the drug, they may need to do anything. They may indulge in criminal activities because it is not their fault. Let us have it very clearly understood. I told you in the beginning that today addiction is believed to be a neurobiological disease with genetic predisposition. It's not their fault. But they cannot control their own brain. They will do anything. Now, as I said, this is very rare with oral morphine. Rare is not nil. It is still a possibility. As in a patient, for example, you treat the person for a long period of time, they are put on morphine, the cancer is treated and cured, but you find it difficult to withdraw. It's very, very rare, but that can be a possibility. Ordinarily, it's not a problem in cancer, but especially if you give morphine for treating a low back pain, this is a greater problem. Again, ladies and gentlemen, any question about opioids and dependence? The distinction between physical dependence and addiction, is that clear?
Sir, I have a question.
Sorry, who is asking? Dr. Sanu?
Yes, sir. Yes.
Yes, Dr. Sanu.
Yeah, sir, in the clinic, is it possible to identify somebody who can develop addiction?
Okay.
And sir, what do you do in your clinics to prevent it or try to avoid it?
The first and foremost, Dr. Sanu, is that considering that you will be treating cancer, the problem is remote. And generally in Western countries, especially in the USA, Canada, and Australia, where inappropriate and non-medical use is an epidemic, unlike in Western European countries, where the principal balance is kept more often. They don't. It's not easy to identify in advance, but once you start the treatment, sometimes some clinics insist on a urine sample when the patient comes to see if they are taking multiple drugs, if there is a high concentration, etc. But one word answer to your question, Dr. Sanu, is no. But if you particularly suspect a problem, then you will screen for, there are screening tools for predisposition to addiction, including the use of past history. But it is not easy, and it is not necessary in the context of cancer. Dr. Sanade, where do you work?
Sir, I work in MVR Cancer Center as a medical oncologist.
Where?
MVR Cancer Center, Calicut.
Okay, MVR. Okay. Any other question? So, I'm going to show you another image. Specifically, as far as opioids are concerned, I have already said what I wanted to say, but let me share another image with you. If tomorrow all our patients are to get pain relief, pain management should not be confined to palliative care units. All of you should be able to prescribe it. Among you, there must be some people who have worked in Western countries. You're able to see my screen, right? Say in anybody who has worked in a European country will know that any doctor is authorized to prescribe morphine. True, you have to go by protocols. But it doesn't have to be a palliative care physician to prescribe to treat pain. It's as simple as that. So if you see the foundation here, certainly what you are doing now, maybe just use of non-opioids and adjuvants. Of course, that will be continued. But if majority of patients are pain relief, you will have to be able to prescribe opioids as a routine. This is the principle of integration of palliative care into all healthcare, which is what is advised by World Health Assembly 8 years back. Many countries have, including several developing countries, have followed this. If I were working in a large institution, this is what I would like to happen. But for this to happen, every clinician has to be schooled in the principles of pain relief. Unfortunately for you and I, our MBBS teaching did not include proper pain relief. Do you know that it is in the curriculum now? From 2019, the students who joined medical college 3 years back, they are in 4th year now. They have pain relief in the curriculum. They have end of life care in the curriculum. But people who joined up to 2018 haven't had in the curriculum. So if all of you have to be able to prescribe opioids, it's also mandatory that all doctors and all nurses should have some schooling in the management of pain. Is that possible to be done? Anybody from Assam in this group? No? Anybody from Uttarakhand? No? Oh. Because in Silchar, in Assam, almost everybody must have heard about Padma Shri Dr. Devikandan, who runs the cancer hospital, Silchar Cancer Center, Catcher Cancer Center in Silchar in Assam. That one, and also Himalayan Institute in Dehradun. These are now pain-free hospitals. What it means is every doctor and every nurse has gone through a short course in pain management. They haven't studied all palliative care, but they have gone through pain management course. And every month they have a refresher course. All new appointees also go through the course. So every 6 months they do a revision course, which is for new entrants into the hospital, which means that any doctor in the hospital treats pain, including the use of opioids. Every nurse has a routine monitors for pain. Every patient admitted to the Silchar Cancer Center or Cancer Relief Institute in Himalayan Institute is asked, every inpatient is asked, do you have pain? If you say yes, it is scored. If the pain score is more than 3, they are offered pain relief by the ward physician. The palliative care unit is called in only if the ward team is unable to treat the pain adequately. It happens. Up to 75% of all cancer pains can be treated easily by everybody. About 25% of cancer pains can be complicated, very often with a mix of nociceptive and neuropathic pains, difficult pains. There, the palliative care team may be necessary. But this is already happening in our country. Understandably, this is easier in smaller hospitals. It is not possible unless the head of the institution is all for it. It is not possible if all senior consultants do not agree to this. But if these conditions are satisfied, institutions can become so-called pain-free hospital. Pain-free doesn't mean that there is no pain. Pain-free hospital only means that everybody is offered access to pain relief. The patient may decide, I don't want it. That's another thing. They are offered pain relief. I am particularly suggesting for one thing to make you aware that this is happening in our country. And secondly, also because in this group, there may be some who may say, okay, can we do this in our place? And then, oh my God, Sri Priya and I and Vaishnav will be very, very happy to work with you to make it happen. Dr. Sanandev is seriously thinking about making MBR Cancer Center a pain-free hospital, especially a hospital where so many oncologists are very tuned into palliative care. Even if not a pain-free hospital, a pain-free department is easier. The whole hospital is maybe too big, but individual department is easier. Individual unit is easier. But without the nurses' cooperation, it will be difficult. They also will have to become part of it. Any question about this? Pain-free hospital concept? Questions, please, or comments? Sri Priya, the session is supposed to have finished at 8 o'clock.
Yes, sir.
Sir, but it started a little late, so it's okay,
Yeah.
sir.
Okay, but I'm happy to close the session unless you have a question.
Sir, good evening, sir. This
Good
is Dr. Sumita from RCC Cuttack, actually.
Yes, doctor.
Odisha.
Yeah.
Sir, sir, I have just one query. Actually, you just told about the procurement of morphine according to the RMI status. That is very, very clear. But is there any other option like procurement of morphine according to NDPS Rule 2? Is it like that?
Dr. Sumita, good to see you
Yes, sir.
again.
Sir.
Dr. Sumita, yes, I have talked only about the RMI status.
Yes,
There
sir.
is another provision.
Yes,
Dr.
sir.
Sumita
Yes, sir.
can apply for permission to stock opioids as an individual doctor, as a medical practitioner.
Yes, sir.
But the catch is the quantity, for one thing, drug controllers do not encourage that a lot, but they permit you. I mean, you can apply. If you insist on it, you will get it.
In our
But,
place, sir, they are doing it. Yes, sir. That's why.
but the quantity that you can keep with you is very
Yes,
small.
sir.
very small
limited.
quantity. That's the catch.
Yes, sir.
So if
Yeah.
it will not be enough for
Yes,
you to
sir.
treat many patients. And the process
Yes, sir.
generally in every state drug controller can decide. In Kerala, our
Yes,
drug
sir.
controller discourages individual practitioners from stocking it because he
Yes, sir.
thinks it will be difficult to monitor. He says
Yes.
apply from the institution.
Yes,
But
sir.
Dr. Sumita, you as a doctor, you have the right,
Yes.
legal right to stock
Yes,
it as
sir.
an individual doctor also. I've not gone into that process here.
Yes, sir. Okay, sir. Thank you,
So
sir.
thank you, Dr. Sumita. Best wishes. So everybody, sorry to keep you so late, but thank you very much for your interest. And I'm so happy to see that you are also you are all together going to reduce the pain burden in India. Thank you. Thank you for making this place, this country a bit safer for me to have cancer in if I have to. Bye-bye. Good night.
Thank you, sir.
Thank you, Sri. Thank you, Vaishnav.
Thank
Thank
you
you,
so
sir.
much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank you everyone for joining, and thank you for your patience during those technical glitches we were having. And with that note, this is Sripriya along with Dr. R Rajagopal, Mr. Vaishnav, and Dr. Ashok signing off from the Tips Eco Hub. See you in the next session, which is
Just a
happening.
reminder, before you go, please do fill the feedback forms, as I mentioned before, and we'll see you for the last session next Wednesday. Thank you.
Everyone stay safe, be happy, be healthy. Bye-bye.